Hello everyone, my name is Barton. This is a Respiratory video for PAR5430. Just a reminder to wear your PPE, gloves, glasses, and if GAN if you are needing, depending on what you're doing. So the first thing we're going to look at is positioning, ramping. Ramping can be used in a variety of patients, but in the obese patient or the difficult airway, you might need to put something underneath them to ramp them up to be able to get their airway alignments, their axes dialed in to help with reducing intrathoracic pressures, allowing better airway movement, decreased potential of gastric inflation, and just allowing for easier access with intubation and airway management. So how we perform this is getting something and putting underneath their shoulders and their head. So with the obese patient, if you think that their chest is quite protruded and our alignments aren't up, which is our ear to our sternal notch, when we lift someone up, we're just trying to bring that into alignment. So if we place something in my very compliant mannequin, his neck's broken, not from me. One more underneath, I think we'll do it. So if we're looking at that, we've ramped them up a little bit and we're getting our ear to our sternal notch. And also bring them up to about 30 degrees. This can also just help with those really obese patients or no neck patients that are able to try and open up their airway a bit better so you can manage it. Something to be cautious about is with your C-spine patient, ramping, you're obviously going to be causing a lot of movement and displacement. So if you do have to do it for whatever reason, mills is going to be the most crucial thing to try and get that neck nice and stable, and just be cautious about how much you do it if you have to do it. Thinking fundamental airway maneuvers, we've got the sniffing position. Excellent position that we can use when we're just trying to align the patient's axes. So with applying a little bit of head tilt, being cautious of C-spine patients of course, what we're doing is we're aligning about 3 axes, our oral, pharyngeal and laryngeal axes. And what this does is, in with putting the sniffing position, allows for airway opening, mouth opening, and like I said, opening up those axes. Some of the things we don't want to do with sniffing is oversniff, undersniff. Head tilt's another one of those fundamental airway maneuvers that can progress into something else as well. So quite simply, like with sniffing, head tilt is all in the name. You tilt the head. Now, it's pretty much sniffing, so what we're trying to do is get the head tilted so we open up the airways, and then we can further on from this something called a triple airway maneuver. So the first part is head tilt. Second part is lifting up the mandible and jaw thrust, which you thrust the jaw open. Now what you're doing there is lifting the mandible up is causing the tongue, which is attached to the jaw and the mandible, to be displaced off the back of the throat. So what we're doing is causing a closed airway by lifting it up to opening it up. So there's some key points and factors that we're trying to achieve with fundamental airways. The first being a neutral position. So if the patient's like this, that's not neutral. You can't sit there like that, breathing adequately. It's not going to work. Hyperflexed, it's not going to work. So neutral position. When we get into our neutral position, what we're trying to do, and what we are achieving, is minimal airway drag. Because if you think, if you've got your mouth half closed and try and breathe, that's a lot of resistance that we're trying to ventilate through when we've got other difficulties. And then of course, minimal flexion. It doesn't need a lot of flexion to achieve a neutral position. There are several airway adjuncts that work well with the BVM. The oropharyngeal airway is excellent. It's a plastic piece that is curved as the shape of the oropharynx. It gets placed into the mouth through a certain technique that we won't describe. And what it does is it displaces the tongue and allows for passive airway ventilation. While there is another great adjunct called the nasopharyngeal airway. So the nasopharyngeal sits into the nasopharynx and runs into the back of the pharynx. Where this differs from the oropharyngeal airway is it's a plastic piece and it gets inserted into the nose. This doesn't cause displacement of the tongue, as opposed to it sort of follows behind the back of the tongue, allowing for passive ventilation, sort of pictured here. There is contraindications and indications for both, as described in the slides. These are from QAS. Now there's a few things to think about our bag valve mask before we start playing with it. And a good one to think about is bones. It's an airway predictor for the bag valve mask. If if there's some things that the patient ticks off with bones, this can predict that our airway is going to be difficult. So the first of all, being B, is beards. Beards are difficult because if we've got vomitus or fluids or whatever it may be, or just the beard itself, it's going to not allow an adequate seal. However, there are ways we can come around this. We can trim with shaver or whatever you might have, or applying some form of lubricant around the outside of your mask, or deflating or inflating until you achieve an adequate seal. O, obesity. Obesity comes back to with our ramping. We want to try and make sure that we've got our airway aligned very well, and this is going to be quite difficult within ventilation with getting your correct head tilt and also airway positioning. No neck, same thing. These patients are very difficult to get aligned, and that's why the bag bell mask can be quite difficult, because a lot of it's to do with positioning and alignment. E is for elderly. Now, if you think about elderly, while they've got potentially reduced movement of their jaws, no teeth. No teeth is an excellent one, because if you think about it, I'll remove this OP for a second. This patient's got teeth, so he's got structure running all the way around his lips. So that's going to create a nice easy seal when we go to place it. If you don't have any teeth, if you feel on yourself where the base of your teeth ends, that's where your gums are going to fall onto. And if you have gums falling down to here, oh sorry, not gums, your lips, apologies, that's going to make it very hard to ventilate. So applying a good technique should hopefully overcome that. And then S, sleep, snore, or stridor. Now this becomes difficult in the regard of tongue displacement, foreign body airway obstruction, or pathological airway obstruction. And if you've got one of those things, you need to think about positioning or other management. You've got to make sure you get the right mask for the right patient. So this is a large adult mask. So how do we know we've got the right seal? So what we want to do is when we place it on, come to the head of the patient, not to the side. I'll just press my bag there. Spread the mask open. Place it initially on the chin, or the mandible, rolling it over to their nose, and trying to make sure that it comes all the way to the tip of their nose. You don't want it sitting like this, because as you can already see there's a gap. You don't want it sitting it like this, because with any movement, you're going to have another gap there. So really important where it sits. Now, there's a few different techniques. I'll show you that. First of all, we've got the CE. C being my index finger and my thumb, and the E being the rest of my fingers. Now how this works is applying our technique, placing the mask on, applying a head tilt, getting our C over the top, holding the top of it, our E being underneath the jaw and down. Now really important that we don't push down, because when we push down in the obtunded patient you will push the jaw down, assisting with occluding your airway. The complete opposite of what you're trying to do. So if we remember, fingers underneath, fingers to bone, and pulling into the mask. That's allowing our jaw to come up and hopefully displacing our tongue. So really important to make sure that we get our seal first, get our C grip down first before we apply our bag. So we've applied our bag, and to measure its success, we look for rise and fall of the chest. Rise and fall of the chest is comparative to the bag. So if you squeeze the entire bag in a bit more, and you get that much rise and fall of the chest, that's not adequate. It's either pathological or it's your seal. But if you go, wee, good amount, good rise and fall, good seal. So if we think about some other ways we can seal, we want to make sure that our patient's positioned nice up on the bed as well, so you can get a good reach to them. And this is called the VE grip. VE. Very similar to the CE grip, but what we're doing is placing all of our fingers to bone. Pinky fingers underneath the mandible, index fingers to jaw, to your chin, apologies. Lifting up and pulling in. You can do this as a two-person or a one-person technique. Two-person, the person managing the airway, so the mica or the intensive care, would generally hold the mask, because that's the more important piece to do, unless you trust a colleague to do it or instruct them because you may need to be doing something else. And then ventilating with one arm. Now, as we're doing that, I can feel that I'm getting a good rise and fall. That's with one person. And with two person, someone else will be squeezing the bag.